It is time to talk about gonorrhea. We've talked about it before. Some of you may remember that we talked about it in conjunction with septic arthritis, right? Because it can be a cause of that. And we'll talk about kind of the presentation of septic arthritis. Even though it's not the most common, it's actually pretty high up on the suspect list. And we've also talked about Neisseria before in some detail. We talked about Neisseria in your brain behavior and cognition block when we talked about meningitis. And I bet you guys can remember the name of the organism because it's very easy. It's Neisseria meningitidis. So we have an understanding of some of the clinical syndromes that Neisseria gonorrhoea can cause, and also some of the cousins of Neisseria gonorrhoea, namely Neisseria meningitidis. We're going to do a compare and contrast of gonorrhea versus meningitis because that's actually a pretty important concept, is being able to differentiate these two different forms of gram-negative diplococci as part of your understanding just from like a microbiology standpoint of how these organisms work. These main characteristics haven't really changed. They're the same as they were for Neisseria meningitidis for the most part, with a couple specific changes. So first off, it's still a Neisseria organism. So it has to have the shape in line with meningitidis. So it's a small gram-negative diplococci, okay? That's what we're going to expect to see, and they're going to be red or pink, right? Because that's what we expect to see with gram-negative, not gram-positive. Once again, humans are the only natural host. We are the problem. One of us has it, we transmit it to someone else, and keep sharing and share alike. So it's transmitted person to person. It's a highly fastidious organism. It has very specific growth requirements, and it must be grown out from specimens on both non-selective and selective media. Your non-selective media would be something like chocolate or blood. Selective media would be something like Thayer Martin. Thayer Martin has antibiotics that will kind of prevent the growth of some other organisms like our staphs and streps, but not typically Neisseria. That said, there are some Neisserial organism species that are susceptible, in which case chocolate is going to be a better option there. It's oxidase and catalase positive, and this one is able to metabolize glucose. Now, remember with meningitis, we also had some alternative carbon sources, but gonorrhea only is able to metabolize glucose. Meningitis can metabolize glucose and maltose, and you can remember that by thinking of the letters that their name starts with. So if we rank gonorrhea higher than we rank meningitis, okay? This is a terrible spelling of meningitis, but you get the picture. Gonorrhea does glucose. Meningitis does glucose plus maltose, okay? So you can kind of think of it in that way. There are some outer surface antigens, including pili and lipooligosaccharides. Those are actually kind of important in both the immune response and the immunopathogenesis of the organisms. The bacteria are able to survive intracellular killing in the absence of humoral immunity. So basically, when they're antibody tagged, then it's pretty helpful. And part of that actually has more to do with complement than it does with intracellular killing, and we'll talk about that in a minute, but it's catalase and oxidase positive. Remember, when we think about intracellular killing, when we think about our phagocytes, a lot of what they're producing are reactive oxygen species, right? Like hydrogen peroxides and things like that. And the catalase and oxidase are designed to break those down, so it might survive that. It also has an endotoxin, and that actually mediates most of the clinical manifestations that you're going to see. All right, let's spend a little bit of time differentiating N. gonorrhoeae from N. meningitidis. I actually kind of adapted this table from the 2018 Step 1 book, the first aid book. I went back and I looked at a couple different years of it. And it appears that it keeps showing up. So I get the impression that on some basic level, the good folk at USMLE want you to be able to differentiate these two organisms. So let's talk just a little bit about them. And there are some significant differences. First off, N. meningitidis has a polysaccharide capsule, while N. gonorrhoeae does not. Now, why is this important? I want you to remember all the way back to your M1 year what the point of a polysaccharide capsule is. Remember, the polysaccharide capsule is like butter on a piece of corn on the cob. Now, if you have a slippery piece of corn on the cob butter and you don't have those corn stickum thingums, you just have to pick up this slippery thing and then try to eat it. And chances are it's going to roll away, roll out of your hands, roll out of you trying to bite it, and you're going to drop it on the ground. Okay. The polysaccharide capsule is slimy and slippery, and it's an anti-phagocytic because it basically makes it more difficult for the neutrophils and macrophages or et cetera to grab onto the organism and ingest it. Okay. Now, in gonorrhoeae, we don't have that problem because there's no polysaccharide capsule, so we don't have to worry about that. But N. gonorrhoeae also has some interesting growth requirements. Both of them can metabolize glucose. Glucose is no problem, and that we're going to find in a lot of different types of media, okay? But only meningitidis can metabolize maltose, and we already talked about that. Vaccines. Thankfully, for meningitidis, we do have some vaccines. The type B vaccine isn't very widely available, but we do have it. And we also have, so it is a vaccine eligible disease. We don't have any vaccines for gonorrhea, and that's partially due to antigenic variation of the pilus proteins. And we'll talk more about that in a minute. How do we get it? And meningitidis, we're going to get that through respiratory and oral secretions, right? Sharing water bottles, water fountains, kissing, close interaction. And gonorrhoeae, that's actually an STI, right? So still close contact, just a different type of contact. What does it cause? Well, for one, and gonorrhoeae causes gonorrhea. It also causes septic arthritis. It is a cause of neonatal conjunctivitis, which we'll talk about it, pelvic inflammatory disease, and a syndrome known as Fitzhugh-Curtis. In meningitis, we're largely worried about meningitis. So you can see meningitis, certainly. You also worry about meningococcemia, right? If you begin to see those petechial hemorrhages in a patient that you are thinking has meningitis, you have to be really concerned that it's N. meningitidis, because you can get gangrene of the toes and it can progress to Waterhouse-Friderichsen syndrome, which basically is that adrenal insufficiency with fever that can lead to DIC and shock. How do we prevent it? We've got some antibiotics for meningitidis. We've also got some antibiotics for the different types of gonorrhea infections, but we can also prevent gonorrhea with good condom use and education. And there's treatment for both. So I think this is a really helpful table to keep them separate. Now, I've mentioned a couple different bacterial structures already that may be important in not only how the organism gets in, but how we defend ourselves from it. Gonorrhoeae attach to the mucosal cells first. So here's our diplococci right here, okay? And it's got a couple proteins. It's got OPA protein and it's got pili, all right? And when they're able to attach to mucosal cells, penetrate the cell, and multiply, they actually pass through the cells into the subepithelial space, and that's where the infection is established. So pili, OPA, pore B, which isn't on here, I don't think, these all mediate the attachment and penetration, okay, into the host cells. Once they get in, so here we go, we have attachment, then we have colonization and invasion. So once they invade, that means they've had to do transcytosis because they've gone across the cell. All right, so now they're beyond that epithelial layer. Now you have these things known as LOSs. These are just lipooligosaccharides. You also have some other PAMPs, right? So pathogen-associated microbial products like peptidoglycan that are going to be picked up by pattern recognition receptors of the innate immune response in the epithelial or beyond the epithelial space, okay? And that's going to lead to cytokine, chemokine, and inflammatory responses, okay? So namely TNF-alpha, that's going to be your big culprit here. It's going to cause most of the symptoms associated with gonococcal disease. Over time, you'll get production of antibodies, notably IgG. It's the primary antibody response found, and it actually is made to pili and OPA. And the LOS actually. So pili, OPA, and LOS is what IgG is going to respond to. Now, here's part of the problem. The pili vary a lot over time. So we can't make a good IgG vaccine to the pili because there is so much variability. LOS antibodies are actually really helpful though, because the LOS antibodies are capable of mediating complement. Remember, IgG is really good at fixing complement. And one of the things that we see is that when there are patients that have complement deficiencies, we actually tend to see an increase in Neisseria infections. And part of that is because complement is required, is helpful. I shouldn't say required, but helpful in destroying the infection, in destroying Neisseria infection, specifically because of the activity of a couple things. One, C5a. C5a brings in neutrophils, and neutrophils are pretty potent at killing things. The other reason is because of the membrane attack complex, so C5b through C8, which are also helpful for getting rid of the pathogen. All right, so clinically, what are we going to see? First off, we're going to see gonorrhea a lot. It's second only to chlamydia for the most reported STI in the US. Last year, there were over 300,000 cases reported in the US and over 100 million new cases worldwide each year. So you're going to see it a lot. Like I said before, there's an increased risk of Neisseria infections in patients with complement deficiencies, right? Because they're going to have a more difficult time activating complement, membrane attack complex, and recruiting innate immune cells. Women actually have a higher risk of acquiring infection from a single sexual encounter than men. It's anywhere, it's close to about 50%, whereas men, it's only about 20% of a single exposure. So there is some gender difference there. In women, though, what's even trickier about this is while women have a higher risk of acquiring infection, women may actually be asymptomatic, and that's bad. Because unfortunately, just because we're not having symptoms doesn't mean we're not affected. It can lead to infertility. And so asymptomatic carriage, particularly in women, becomes kind of a major reservoir for gonorrhoeae. And it's more common in women than men. As many as half of all the infected women have a mild or asymptomatic disease, where almost all men initially are asymptomatic but then present with symptoms. So what are the symptoms? Well, first off, generally, the symptoms are going to clear within a few weeks in individuals with untreated disease, and asymptomatic carriage might be established at that point. The site of infection is going to determine whether carriage occurs. Rectal and pharyngeal infections are more likely to be asymptomatic than genital infections. Okay, so there is a site difference as to whether or not you're going to feel that you have gonorrhea or not. Doesn't mean you don't have it, just means you're not feeling it. All right, so let's talk about genital gonorrhea infection. Genital infection in men is primarily restricted to the urethra. And you're going to see this purulent urethral discharge, as I'm showing here. The dysuria will also develop, and this is these things are going to come in after about a 2 to 5 day incubation period. Virtually all infected men will have acute symptoms, although complications are pretty rare. Sometimes we see them, epididymitis. inflammation of the prostate. You can also see periurethral abscesses. So these are rare, but you might see them. In women, the primary site of infection is the cervix. And this is basically a cell type issue. The bacteria infect the endocervical columnar epithelial cells. Symptomatic patients, which are not common in women, might experience some vaginal discharge, dysuria, maybe some abdominal pain, and then you can get these ascending genital infections. And that's what the real risk is, because in women, since we're largely asymptomatic, what happens is when it ascends, you can wind up with salpingitis. And when you get inflammation of the fallopian tubes like that, that's what down the line could lead to infertility. And so it's kind of a compounded problem that if we'd known about it, we would have treated it. But since we didn't know about it, now there can be a long-term effect that obviously can be very distressing. We also see pelvic inflammatory disease in women. And these symptoms, salpingitis, tubo-ovarian abscesses, pelvic inflammatory disease, or these conditions are observed in about 10 to 20% of women, whether they experienced acute symptoms or not. So asymptomatic patients may still experience these things. Of note and of concern is that we're actually seeing a significant increase in multi-drug resistant gonorrhea. So this is an infection that, as I've mentioned before, is highly prevalent throughout the world. We're the only host of it, and resistance is going up. So something to certainly be aware of. All right, gonococcemia. This is a disseminated infection with septicemia. Often we'll see infection of skin and joints. It occurs in about 1 to 3% of infected women, and actually in a much lower percentage of infected men. And so in this case, you're expecting to see fever. This is where we would expect to see that migratory arthralgia or suppurative arthritis in the wrists, the knees, the ankles. You might also see this pustular rash on the extremities, but not on the head and trunk. That's kind of a major differentiating factor for it. It is a significant cause of purulent arthritis in sexually active adults, depending on your pool. Okay, ophthalmia neonatorum. This is a fancy way of saying Neisseria gonorrhoea in the eye. This is infection of the conjunctiva in neonates, and it's acquired as the baby passes through the birth canal. It causes a purulent conjunctivitis with really profuse exudate and swelling of the eyelids, and without treatment, it can lead to blinding, ulceration, big problem. It's going to manifest 2 to 5 days after birth, and this needs to be treated quickly. And largely it is. This is an easy one. You can treat it topically, almost kind of prophylactically, like as the baby comes out, just kind of put something on the eyes, put an antibiotic on the eyes, and one singular treatment, just that one time right after they came out, and they're good. So it's a fairly easy one to treat in that respect. Okay, Fitzhugh-Curtis. This is a rare complication of pelvic inflammatory disease. It involves the liver capsule. So you get inflammation of the liver capsule, which basically leads to the creation of adhesions and can also lead to perihepatitis. So I'm going to leave this one alone. If you have questions about it, you can talk with your pathophys or pathology discipline directors. All right, how are we going to diagnose it? This is actually a little bit tricky, right? Because a lot of people are asymptomatic. At Rush, this is exclusively done by PCR. And who are you going to test? Because we can't test everybody that walks through the door just because a lot of people are asymptomatic. So it's made based on a history of unprotected sex. And then if you have a history of unprotected sex, you're going to use swabs for any orifice of the body that was used for sex in both genders. I'm not going to list them, but I'm sure you can figure that out. If you have patients with extragenital symptoms, for example, pharyngitis, and a history of unprotected oral sex, that should also prompt molecular testing for Neisseria gonorrhoeae. And again, you're just going to use a pharyngeal swab and then perform PCR. or order PCR in most cases. Since there's a large number of gonococcal infections, which are asymptomatic, routine molecular testing should be offered to sexually active patients who are in a high risk of infection. So for example, of infectious complications, sorry, not infection. So for example, HIV patients, sexually activated individuals living in really high areas of gonorrhea prevalence, individuals with a history of other STIs. Chlamydia and gonorrhea are like best friends. They hang out all the time. So if you've got one, you got a pretty high likelihood of having the other, unfortunately. So we'd like to know so we can treat them all together. Any individual entering a correctional facility, also a good idea to have them tested and treated so that we are able to take care of that before introducing another person into that particular environment. Right? How are you going to find it? You could technically do a gram stain of urethral specimens, but this isn't really helpful, right? Because it's really only going to work on symptomatic males who have that purulent discharge. So that's why PCR is really the better option. Culture is sensitive and specific, but really it's been replaced by nucleic acid amplification assays in most labs, including ours. Okay, how are you going to treat it? The CDC recommends that you screen all mothers. Okay, so while women are pregnant, we screen them. Well, all mothers with an increased risk of infection, but largely that means you're screening mothers. Neonatal prophylaxis can be administered up to 1 hour after birth using topical ophthalmic erythromycin ointment. So if there's any sort of risk whatsoever, just a little bit of erythromycin on the eyes, baby's fine. Ceftriaxone with either azithromycin or doxycycline is kind of the treatment of choice for other forms of gonorrhea, not neonatorum. But there has been kind of a high level of resistance to cephalosporins observed. And honestly, our best option right now is education and proper condom use. Educating the public and using condoms effectively is really our best bet because we don't have a vaccine.